Good evening, everyone. Am I audible and visible, guys? Please let me know in the comment section. Yes, just confirm me once so we can proceed. Okay, thank you. Okay, guys, good evening, everyone. Welcome to the session, High Discussion Obstetrics and Gynecology Part 3. Okay, I've already done, guys, Part 1 and Part 2, and I hope that was useful enough. So today is going to be the final part. That's a Part 3, Obstetrics and Gynecology High Discussion. Okay, so same way, guys, we will proceed. Good evening, good evening. Good evening, everyone. So same way we are going to proceed, guys. Question followed by that all the important topics. Good evening, Salman. Okay, so question and followed by that we'll have a whole discussion of that particular topic. Okay, so I hope you have revised, you have watched part 1 and part 2. Just watch that part 1 and part 2 at least 2 times. Okay, we are done with till here, guys. So we are going to start with the part 3. Good evening, good evening. Okay, so let's begin, guys. Okay, so without any further delay, guys, let's begin, and we have to complete full rapid revision by today. Okay, guys, we are left with around 40-50 pages. So this is the final part 3 discussion. Okay, so let's begin with the question number 1. A 20-year-old girl presents to you with a cramping abdominal pain. It starts at the onset of menses and it's more pronounced on the first day. This pain started around 15 years of age. Which condition is she likely suffering from? Which condition is she likely to be suffering from? Okay, so your diagnosis is, guys, your diagnosis is, it is dysmenorrhea. So pain during the menses, it is dysmenorrhea. Okay, pain during menses, that's called dysmenorrhea, and dysmenorrhea is a normal condition. Okay, and dysmenorrhea is a normal condition. Dysmenorrhea is a normal condition. Okay, now, guys, we have a different types of dysmenorrhea. Okay, now let's discuss, sir, is this enough for FMGE? Yes, it is enough only when you have studied your primary notes. Okay, first you revise your primary notes, whatever source you are studying from, then these rapid revisions, high discussions are good enough. Okay, they will be productive enough only when you will revise the full course. Okay, but yes, all the topics that I'm discussing, guys, nothing outside that will come for sure, because I'm focusing on the main things. Rest is up to the NBE, nobody knows. Okay, so now, guys, we have a different types of dysmenorrhea. Okay, so we have different types of pain. For example, we have a primary dysmenorrhea, we have a secondary dysmenorrhea, we have a membranous dysmenorrhea. Okay, so let's discuss one by one. First of all, let's discuss what is primary dysmenorrhea. Let's discuss what is primary dysmenorrhea. Primary dysmenorrhea, it's also called as spasmodic dysmenorrhea. Primary dysmenorrhea, it's also called as spasmodic dysmenorrhea. Okay, so spasmodic dysmenorrhea, guys, what is this? It means when the pain starts 30 minutes before the onset of periods. Before the onset of menses. Okay, so when the pain starts 30 minutes prior to the cycle, guys, that particular dysmenorrhea is called as spasmodic dysmenorrhea or primary dysmenorrhea. We have a second type of dysmenorrhea, guys, called as secondary dysmenorrhea, which is called as secondary dysmenorrhea. And the other name of secondary dysmenorrhea, what is another name for secondary dysmenorrhea, guys? It is congestive dysmenorrhea. It's also called as congestive dysmenorrhea. Okay, which means that the pain will start 3 to 4 days prior to the onset of the cycle. Pain starts 3 to 4 days prior after menses. Okay, and it will remain throughout the cycle, and this pain will remain throughout the cycle. Okay, can we get the PDF? Yes, you can get the PDF of this session. You guys can ping me on the Telegram. I will share you the PDF. Okay, for now you just only focus on the sessions. Okay, any single doubts, guys, you can ask me while during the session. But yes, other than the topic doubt, all the doubts I will take in the end of the session. Okay. Now we have one more type of dysmenorrhea called as membranous dysmenorrhea. Now what exactly means this membranous dysmenorrhea, guys? Now we have a fibrinolytic system in our body. Okay, so during the menses, what happens that it will cause a less clumping of the blood. Okay, this fibrinolytic system will cause a less clumping of the blood, so there will be no pain. Okay, but in case this fibrinolytic system in the body is absent, what will happen to the blood, guys? There will be more clots, there will be more clumping of blood. When there is a more clots and more clumping of blood, what exactly will happen? We need more contractions to pass those clots. Such type of the pain which will be caused due to the absence of the fibrinolytic system in our body, such type of dysmenorrhea, such type of pain is called as membranous dysmenorrhea. Okay, I'll repeat this particular type of dysmenorrhea, guys. That means we have a fibrinolytic system in our body which will prevent the we have a fibrinolytic system in our body which will prevent the clumping of the blood, or which will prevent the clot formation. Okay, but when this system is absent in the body, okay, when this system is absent in the body, what will happen? There will be more clumping of the blood, more clots. So when there are more clots, we need more contractions to pass these clots, and the pain because of that is called as membranous dysmenorrhea. Membranous dysmenorrhea. So write it down, guys, clear cut. The absence of fibrinolytic system will cause more clumping or more clots, more clumping of blood or more clots. When there is more clumping of blood and more clots, what will happen, guys? More contractions. We need more contractions to pass those clots, and when we have more contractions, we'll have more pain, will have more pain. Is it clear, guys? So that is which type of dysmenorrhea? Membranous dysmenorrhea. Okay, we have one more type of pain called as mid-cycle pain. Okay, mid-cycle pain, which is also called as Mitchell-Marsh pain. It is the pain during the ovulation. It means the pain during ovulation. Okay, so what happens during the ovulation? This debris, this blood, it is accumulated. Debris, red cells, this blood is it is accumulated in the pouch of Douglas, guys, and the pain during that is a mid-cycle pain. Okay, so the in equation, while asking the mid-cycle pain, it will be given, for example, if the patient has a last menstrual period on 15th of July. Okay, it will be mentioned that she's coming to you on 30th of July. So 14 days after that, you predict as per the normal cycle that the mid-cycle, and the patient is having a pain abdomen. On routine urine examination, it is normal. So what exactly is the cause, guys? It's a mid-cycle pain or the Mitchell-Marsh pain, which is due to pain during the ovulation due to the debris accumulated in the pouch of Douglas. So it was all about the pain during the menses or during the cycle. So what was the question, guys? It was saying that this pain started at the onset of menses. Okay, so 10 to 30 minutes prior to the onset of menses. So 30 minutes prior to the onset of menses, it is, what is the answer, guys? It is spasmodic dysmenorrhea. So what is your answer, guys? It is spasmodic dysmenorrhea. The pain starts 30 minutes before the onset of menses. Is it clear, guys? So question number 1, that was all about dysmenorrhea and the types. How can A means congestive dysmenorrhea. That means 3 to 4 days. Okay, that means that is 30 minutes. 3 to 4 days is congestive. Let's move to the, is it clear, guys? Okay, what can be the management? So what will be the management of dysmenorrhea? You already know, guys, management of dysmenorrhea. Tell me. The management is NSAIDs. Okay, the NSAIDs are the management, guys. like mefenamic acid, ibuprofen, naproxen. Antispasmodics, you can take drotaverine, spasmofort, antispasmodics. Okay, we also can take OCPs, but they will cause irregular cycles. We can go for the surgical treatment for the surgical dilatation of the cervix. What will happen when the cervix is dilated, guys? These clots will be easily passed. Okay, so it was all about what we can also use GnRH analogs, guys, but there will be the absence of the menses by doing the down regulation of the pituitary. Okay, so that is all about what dysmenorrhea and the management. Is it clear, guys? Everyone, be interactive and keep commenting, guys. Is it clear to everyone? Chalo. Question number second. A 28-year-old woman presents to the psychiatry OPD. She is presenting to the psychiatry OPD with the complaints of mood swings, palpitation, approximately 5 to 7 days prior to her menses. This is associated with breast tenderness and bloating. Her symptoms resolve once menses begins. What is a treatment in this case? Okay, what is the treatment in this case? Okay, so what is your diagnosis, guys? What is your diagnosis? It's premenstrual syndrome. PMS. Okay, guys, premenstrual syndrome. Okay, now what can be the cause of this premenstrual syndrome, guys? Write down the causes. What can be the cause of this premenstrual syndrome, guys? It can be due to the excess estrogen or progesterone. There are multi-factor causes, guys. There are not a single cause. Okay, it can be due to the emotional causes, it can be due to the hormonal change, it can be due to the deprivation of the sleep, it can be due to the stress work. Okay, it can be also due to the pyridoxine deficiency. Okay, stress, workload, okay, sleep deprivation. Okay, these can all be the causes of what premenstrual syndrome. And what is the classical drug of choice for most of the conditions in the psychiatry, guys? Selective serotonin reuptake inhibitors, so SSRI. So what is your drug of choice, guys? Your drug of choice is fluoxetine. Your drug of choice is fluoxetine for premenstrual syndrome. What is your drug of choice, guys? Fluoxetine. Okay, now let me discuss here very important question from the psychiatry and obstetric point of view, guys. Psychiatric disorders. So let me discuss psychiatric disorders. So we have three disorders mainly. Psychiatric disorders. We have postpartum blues. We have postpartum blues. Okay, number one. Number second, guys, we have postpartum depression. Number second, we have postpartum depression. Okay, number third, we have postpartum psychosis. We have postpartum psychosis. Okay, now let's discuss one by one, guys. This is a PYQ asked about the postpartum blues. So what is postpartum blues, guys? It occurs in first few days. It occurs in first few days and resolve by 2 weeks. And it resolved by 2 weeks. Okay, so what can be the symptoms of this patient, guys? The transient symptoms. Okay, very good. The transient symptoms like decreased sleep, loss of appetite, sad, low mood. Okay, so write it down, guys. In the question they will mention transient symptoms, but more important than that is a time period. Okay, more important than that is a time period. So when it is mentioned that she has delivered a week ago, 5 days ago, and she's having those transient symptoms, what can be the symptoms? So it can be decreased sleep. Okay, it can be decreased sleep, it can be decreased appetite, okay, and low mood. These transient symptoms after the 3 to 4 days after the delivery, your diagnosis is postpartum blues. Your diagnosis is postpartum blues. Okay, then the postpartum depression, guys, it occurs, write it down, it occurs in 3 to 6 months. Postpartum depression, it occurs in 3 to 6 months. Okay, and what can be the symptoms? Depression like symptoms. Okay, anhedonia, suicidal thoughts, लिख दो, anhedonia or suicidal thoughts, depression like symptoms, है ना. You might have studied that in a detail in the psychiatry, but yes, from the OB/GYN point of view, this question is important. Okay, then the postpartum psychosis, guys, it's very rare. It's very rare. Okay, it is within 2 to 3 months. It occurs within 2 to 3 months. And we have psychotic symptoms. We have like delusions, hallucinations will be mentioned in the clinical case. Okay, patient will have delusion, hallucination. Okay, so that's all. Okay, so postpartum blues, depression, and postpartum psychosis. Okay, so drug of choice again, fluoxetine. Drug of choice again, SSRIs, selective serotonin reuptake inhibitor. Okay, like sertraline, depoxetine, all these are what? SSRIs. Is it okay, guys? Chalo, guys, further. Now it's clear, guys. Postpartum psychosis, premenstrual syndrome, postpartum blues, and postpartum depression. So remember the time, guys, within the first few days, 3 to 6 months, 2 to 3 months. Okay, after that you will go with the symptoms. Okay, transient symptoms in blues, depressive symptoms in postpartum depression, delusion and hallucination in case of postpartum psychosis. Brexlone, I don't know about that, Brexlone, but mainstay of the treatment as SSRIs. Okay, it can be an additional drug. Chalo, a 25-year-old primary gravida female is on a lithium. Okay, now 25-year-old primary gravida, a pregnant lady is coming and she is on a lithium therapy. She's on a lithium therapy for her psychiatric illness from past 2 years. Okay, the most common anomaly seen in the fetus whose mother is on the lithium during the pregnancy. Okay, again an important question, guys. Again an important question that it was asked. Not exactly the same question, but question was asked about the side effects of lithium. Okay, the question was asked from the side effects of the lithium. So remember, guys, let's remember with the mnemonic side effects of lithium. LITTH. So these are the side effects. L stands for the leukocytosis. Leukocytosis. I stands for the insipidus diabetes. Insipidus diabetes. T stands for the tremors, which is the most common side effect. Okay, T stands for it is an teratogenic. It's teratogenic, causing a Obstein anomaly. क्या cause करता है, guys? It causes Obstein anomaly, and this Obstein anomaly, guys, which shaped heart we have? Box shaped heart. Okay, and H stands for hypothyroidism, and H stands for hypothyroidism. Okay, so these are the side effects of lithium. LITTH. Okay, then further, guys, so what is an answer over here? The most common anomaly which is seen, guys, that goes with Obstein anomaly, side effect of the lithium. Okay, insipidus diabetes. If I talk about insipidus diabetes, guys, we have 3 types. We have central, we have nephrogenic, and we have drug induced. I will write it here, guys, for extra point. Insipidus diabetes due to the decreased anti-diuretic hormone. Insipidus diabetes. So 3 questions can be asked, guys. If it is central, okay, your drug of choice will be desmopressin. अगर vasopressin कम होगा तो desmopressin देंगे ना. Anti-diuretic hormone is also called as vasopressin. Okay, then if it is nephrogenic, अगर nephrogenic दिया हुआ है, your drug of choice will be thiazides. Your drug of choice will be thiazides. Okay, and if it is lithium induced, diabetes insipidus, your drug of choice will be amiloride. Your drug of choice will be amiloride. So desmopressin, thiazides, and amiloride. Desmopressin, thiazides, and amiloride. Is it okay, guys? Then PDA, guys. PDA in the OB-GYN. PDA, patent ductus arteriosus, you already know. But obstetrics and gynecology में कहाँ पे मिलता है, guys? It is seen in congenital rubella syndrome. Okay, कहाँ पे दिखता है? Congenital rubella syndrome. The classical triad of cafe coffee day, CCD, where C stands for cataract, C stands for congenital heart defect. Okay, the most common heart defect associated with congenital rubella syndrome. Question FMG PYQ. Okay, your answer goes to PDA. याद रखना. And D for deafness. ऐसे नहीं होता है. Okay, so remember this as well. Okay, anything else, guys? Then NTD, guys. VSD is associated with the infant of a diabetic mother. Okay, VSD, most common will be their transposition of great arteries followed by the VSD. Neural tube defects, you already know, guys. The neural tube defects occur in the pregnancy due to the deficiency of a folic acid. That's why if a patient is having a history of a folic acid 4 mg per day, not a history of a folic acid 0.4 mg per day to be given. Okay, but as per the Anemia Mukt Bharat 500 micrograms, 1 point, the most common neural tube defect goes to the spina bifida. Okay, and most common spina bifida is your spina bifida occulta. 2 signs, guys, in the cerebellum: banana sign and a lemon sign. Okay, anything else about neural tube defects? Yes, how to diagnose these neural tube defects? By checking the acetylcholinesterase in your amniotic fluid. By checking the acetylcholinesterase in amniotic fluid. So it's clear, guys. So integrated discussion for this particular question, guys. Remember, insipidus diabetes, याद रखना, decrease ADH. दूसरा नाम क्या है? Vasopressin, VP. Okay. No. Most common congenital heart disease in case of a congenital rubella syndrome, it's patent ductus arteriosus, PDA. है ना? And diabetes में मैंने बोला it's transposition of great arteries. Cardiac anomalies होती है, not VSD. चलो. Next question, guys. Is it clear, everyone? Write down in the comment section. All clear? Let's move to the next question. Sure. Okay. Now, a female has a previous history. A female has a previous history of cesarean section. A female has a previous history of a cesarean section and prolonged labor. She's hypotensive, fetal heart rate can't be heard, and fetal parts are palpable superficially. Now, guys, you have a patient, fetal heart, she's a pregnant lady. Okay, she had a history of she was a previous cesarean section, and now she's having a prolonged labor, guys. What do I mean by prolonged labor? In primary gravida, when combining the first and second stage, if it exceeds 18.5 hours, I call it as a prolonged labor. Okay, first and second stage. And if a patient is having more than 30 minutes from a third stage, I call it as prolonged third stage of the labor. That means the contractions are not adequate. Okay, either she can be in the active phase only, not more than 4 centimeters. She's not going beyond that. Okay, now after this, guys, she's hypotensive and the fetal heart rate cannot be heard and the fetal hearts can be felt. Okay, now you can see that you can palpate and see the fetal parts are palpable. Okay, in my first discussion of part 1, I have already told you the hint about the condition when a patient will come to you with the complaints of the bleeding, fetal heart rate cannot be heard, fetal parts can be palpable. Your diagnosis is uterine rupture. Okay, image I have deliberately given here, guys. Image won't be given in the question, so in order to explain the things. Okay, so these questions are more about a discussion. Okay, don't expect same questions will come 50-50 ho sakta hai, but our main part is to discuss a topic. Okay, now, guys, if the fetal parts cannot be palpated, your diagnosis will go to the abruptio placenta. But if the fetal parts are palpable, that means that parts are coming outside the uterus. Okay, the baby feet parts can be felt in the cavity, है ना, abdomen के बाहर आ गए हैं. So what is the diagnosis, guys? Uterine rupture. Okay, and this is a classical complete rupture. This is a complete rupture. Okay, now sir, what is complete rupture and what is incomplete rupture? Okay, so write it down. Incomplete rupture. By incomplete rupture, guys, I mean when the visceral peritoneum is intact and the fetus remains in the uterine cavity. When the visceral peritoneum is intact and fetus remains in uterine cavity. And fetus remains in the uterine cavity. That means all the layers are not ruptured. Okay, baby is still intact. Uterine dehiscence also same like that. Okay, incomplete rupture. What is complete rupture? When all the layers including peritoneum are torn. So write it down, guys. All the layers including peritoneum are torn. Including peritoneum are torn. That is a complete incomplete rupture. So complete rupture, incomplete rupture. The classical hint is fetal parts are palpable. So fetal parts are palpable, guys, you go with the uterine rupture. Fetal parts not palpable, given the history, tender uterus and all, pain, you go with the abruptio placenta. Abruptio placenta. Chalo, next question, guys. A 35-year-old gravida 3, para live 0, abortion 2. Okay, it's the third time she's pregnant. So gravida means how many times she got pregnant. Okay, she's presented with the 20 weeks pregnancy, pain abdomen. USG bedside was done, showed the funneling of the cervix. Okay, the cervical length is 21 mm. What will be the best management for her? What will be the best management for her? So what is your classical diagnosis, guys? When the given is 21 mm, that means it is 2 centimeter. Okay, guys, it is 2.1 centimeter. Okay, your diagnosis is less than 2.5 centimeter. That means short cervix, which is called incompetent cervix. क्या बोलते हैं? Incompetent cervix or short cervix. Incompetent cervix or short cervix. Okay, so how to manage this incompetent cervix or short cervix? We already know when it is less than 2.5 centimeter, it will cause abortion. क्या होगा, guys? Abortion. Which trimester abortion will happen, guys? Mainly second trimester abortion. We have discussed in our abortion, guys, topic that we have discussed. Yes, it can predispose. Yes, it can predispose to the preterm labor and abortion. Okay, short cervix can predispose to the preterm labor and abortion. Now, main thing, guys, here. So remember, guys, first trimester abortion mainly chromosomal causes. Okay, chromosomal causes. Second trimester abortion causes, it can be a Mullerian defect like septate uterus. Septate uterus. It can be bicornuvate uterus. Or it can be incompetent cervix. Or it can be incompetent cervix. These are all the second trimester abortion causes. Now, guys, let's discuss all the management of these three things. If I talk about septate uterus, one by one. If I talk about septate uterus, okay, it's a most common Mullerian defect, and the treatment is by, what is the management, guys? Hysteroscopic resection. Your treatment is hysteroscopic resection. Your treatment is hysteroscopic resection. If I talk about bicornuvate uterus, your treatment will be Stressman metroplasty. Your treatment will be Stressman metroplasty. Okay. If I talk about incompetent cervix, you will go with the cerclage. Most common cerclage used is it's less than 2.5 centimeter. The management is cerclage, and the most common cerclage that we go for is called as McDonald cerclage. It is McDonald cerclage, okay, and it is applied. This McDonald cerclage, it is applied at 12 weeks and it's removed in the term 37 weeks. Remember that, okay? It is applied by 12 weeks and removed by 37 weeks. We can apply, starting is 12, we can go up to 16, 17 weeks, okay? And it's removed on 37 weeks. So 3 types: septate uterus, bicornuate uterus, and incompetence cervix. These are all the causes of which trimester abortion, guys? Second trimester abortion, okay? So what will be your answer here, guys? When the cervical length is 21 mm, that means 2.1 centimeter. Incompetent cervix, it is McDonald stitch. It is McDonald stitch. That's why she's having abortion, guys. See, two history of twice an abortion is given in the question. Let's go further. Next question. Is it clear, guys? So second trimester abortion, incompetent cervix, your management is McDonald cerclage. Chalo, guys, next question. Okay, a pregnant lady having a 2-year-old child had come for an antenatal checkup in second trimester. So she is an ANC case coming for a checkup trimester. Recommended dose of tetanus toxoid. So write it down, guys. Pregnancy vaccination. Pregnancy vaccination. If I talk about vaccination in pregnancy, guys, if primary gravida is coming, what do I mean by primary gravida, guys? She is pregnant for the first time. She has conceived for the first time, okay? What will be your management, guys? 2 doses of TT given. Okay, 2 doses of tetanus toxoid. 2 doses of tetanus toxoid, primary gravida. Okay, when to give? If I talk about the first dose, in the pregnant lady who's a primary gravida, as soon as possible. Okay, and the second dose, you will give 4 weeks prior to the term. 4 weeks prior to the term. Okay, as soon as possible. Second dose you can give at 4 weeks prior to the term, or 3 weeks prior to the term, and gap between these two, okay, guys, gap between these two should be what? 4 weeks. Gap between these two should be 4 weeks. Okay, gap also should be 4 weeks. Then if she is a multi-gravida, if her last childbirth is less than 3 years back, I'm writing LCB, last childbirth less than 3 years. How many doses you will give, guys? Single booster dose. Write it down, single booster dose. And if it is more than 3 years, if the last childbirth is more than 3 years, then 1 dose. Sorry, if the last childbirth 3 years, then 2 doses. Then you will give 2 doses. Is it clear, guys? So pregnancy vaccination, primary gravida 2 doses, multi-gravida last childbirth less than 3 years, single booster more than 3 years, 2 doses. That is a pregnancy vaccination. So she has a last childbirth, she has a 2-year-old baby, and she's coming for the checkup now. What will be your answer? You go with the tetanus toxoid booster. Okay, not TT booster, tetanus toxoid booster. Chalo, guys. Next question. If the division of a fertilized ovum occurs between day 9 and day 12, okay, from the twin pregnancy, guys, if the division of the fertilized ovum occurs between day 9 and day 12 after the fertilization, name the type of twins. Okay, so let's discuss, guys, fate of monozygotic twins. Fate of monozygotic twins. Okay, if we discuss the fate of monozygotic twins, guys, first of all, if the cleavage will take place between day 1 and day 3, 1 to 3 days cleavage is taking place, your answer is dichorionic diamniotic. Dichorionic diamniotic, dichorionic diamniotic. So you will remember guys, D, okay, dichorionic diamniotic. If the cleavage is taking place between day 4 to day 8, you will remember guys, monochorionic diamniotic, monochorionic diamniotic. That's monochorionic diamniotic. Okay, if the cleavage is taking place between day 9 and day 12, day 9 and day 12, you will remember momos, monochorionic monoamniotic, monochorionic and monoamniotic, monochorionic and monoamniotic. Okay, and if the cleavage it is more than 13 days, you will have conjoined twins or Siamese twins. क्या होंगे फिर guys? Conjoined twins or Siamese twins. So that is about a fate of a monozygotic twins. Okay, if I talk about the signs guys, now here between day 9 and day 12, you will go with the monochorionic monoamniotic. So monochorionic monoamniotic twins are when the after the fertilization, the cleavage takes place between day 9 and day 12, you will have momo twins. Okay, now what is the sign guys? What is the sign in dichorionic diamniotic? Remember guys, what is the sign? It is called as twin peak sign. कौन सी sign होती है guys? Twin peak sign. The another name for the twin peak sign, it is lambda sign, sir. It is lambda sign. Okay, so didi lambi hai. Dichorionic diamniotic, you have a twin peak sign or a lambda sign. Twin peak sign or a lambda sign. If I talk about a diamniotic or monochorionic twins, which sign we have guys? T sign. कौन सी साइन मिलती है गाइज? ऑन द chorionicity scan, twin peak sign and the lambda sign are seen in dichorionic diamniotic twins, and T sign it is seen in monochorionic and diamniotic twins. I'll show you the classical picture of these. I'll show you the classical picture guys of this. Here it is guys, see, chorionicity scan. Okay, you have a intertwin membrane thickness more than 2 mm, and this classical sign it is called as lambda sign. Can you see guys, lambda sign in dichorionic and diamniotic pregnancy? And here guys, this is called as T sign. Okay, this is called as T sign, monochorionic diamniotic. Okay, chorionicity scan guys, remember दीदी में दीदी लंबी है तो lambda sign. Okay, and modi T sign. Okay, remember with the monochorionic diamniotic with the T sign. So it was about a chorionicity scan. Okay, chalo guys, further let's go to the next question. Is it clear guys, fate of a monozygotic twins? Everyone write down in the comment section, is it clear to everyone? Clear to everyone? Yes. So remember guys, there is from the twin pregnancy, what can increase the chances of twin pregnancy guys? Okay, multigravida, old age, and infertility treatment like IVF, or the drugs like aromatase inhibitors that are used for an ovulation induction, letrozole, clomiphene citrate. Okay, these are all the causes of what? Twin pregnancy. They can predispose to twin pregnancy. Chalo, further, next question. A 35-year-old lady presents with gravida 3 para 2 livo abortion with 37 weeks of pregnancy. She has a profuse bleeding. Now a patient is coming to you with a bleeding. USG showed a central placenta previa. Okay, she is a diagnosis of placenta previa. What is placenta previa, sir? When the placenta is on the internal os. Okay, when the os is covered by a placenta completely, it's a complete placenta previa. If partial, if half os is covered, incomplete or the partial placenta previa. If the placenta is 2 centimeters away from the internal os, that is low lying placenta. Okay, so different types of placenta previa. Okay, we have further classifications we have discussed in our main classes. Now at 32 weeks, on examination her vitals are stable. What will be the next line of management? So guys, a patient is coming to you with a bleeding at 37 weeks, a diagnosis of placenta previa. Guys, in my notes I have a clear cut things mentioned. Okay guys, patient coming to you, complaints of placenta previa at term. Your clear cut answer is LSCS. What is your answer guys? LSCS. Now further discuss guys, let's discuss placenta previa. Okay, a patient is having painless bleeding. A patient is having painless bleeding in presentation of the placenta previa. Okay, now guys, placenta previa bleeding, it is a type of an antepartum hemorrhage. What is an antepartum hemorrhage guys? It's a type of an obstetric hemorrhage which occurs after the 28 weeks of the pregnancy till the delivery. After the 28 weeks of pregnancy till the delivery, it is called as antepartum hemorrhage. It can be due to the placenta previa, it can be due to the abruptio placenta, or it can be due to the vasa previa. But the classical symptom that you will differentiate abruptio placenta with other two things. In abruptio placenta there is painful bleeding. Okay guys, in abruptio placenta there is painful bleeding. Okay, now in placenta previa guys, what is important? Management. So let's discuss the management. Placenta previa. Okay, management. Placenta previa management. Now if I talk about a placenta previa bleeding at term, placenta previa bleeding at term, that is 37 to 42 weeks. 37 to 42 weeks, your answer goes to cesarean section. Okay, so placenta previa at term, cesarean section. Okay, if placenta previa at term, if placenta previa at term, if it is a low-lying placenta. What do I mean by low-lying placenta guys? That means it is not covering the os. Okay, it is 2 centimeters away from the os. That means door is still open, os is still free. Okay, 2 centimeters away from os. What will be your management guys? You will go for trial of normal vaginal delivery. You will go for trial of normal vaginal delivery. Okay, and now if you have a posterior low-lying placenta, posterior low-lying placenta, in a posterior low-lying placenta there are increased chances of a cord entanglement in the baby which can cause a fetal distress. So your management will be guys, continuously monitor the surveillance, monitor the heart rate. If the fetal heart rate is less than 100, you go with the cesarean section. Okay, now if you have a patient coming to you at 32 weeks, placenta previa at 32 weeks, that means placenta previa at 32 weeks, that means in a preterm. Okay, 32 weeks mein aayega, you will go with the expectant management. The classical regime you have Mackay-Johnson regime. You have a regime called as Mackay-Johnson regime. What is a Mackay-Johnson regime guys? You will go with a resuscitation. You will go with the resuscitation plus you will give a patient rest, admit the patient, you will give a steroids to the patient, you will check the fetal lung maturity by checking the phosphatidylglycerol in the amniotic fluid. If it is present, fetal lungs are mature, still give steroids. Okay, you will give steroids beta-methasone and dexamethasone, 2 doses of beta-methasone, 4 doses of dexamethasone. Okay, and arrange the blood. That is a Mackay-Johnson regime. That is a Mackay-Johnson regime. So placenta previa less than 37 weeks, simple thing, sir, expectant management, Mackay-Johnson regime. Placenta previa at term, cesarean section. Now if a placenta previa will come at 36 weeks but the fetal heart rate is less than 100, at that time your answer will go to what? Cesarean section. Okay, conditions applied. So simple way guys, if I'll show you from the main notes, see guys, from the main notes, easy way to remember this placenta previa here. So after you diagnose this placenta previa guys, after this diagnosis, see, this is a complete placenta previa, this is a low-lying placenta previa, and this is a normal placenta. Okay, and now let me, yeah, okay. Now a patient is coming to you with a diagnosis of a placenta previa. So placenta previa is already diagnosed. If it is less than 37 weeks, guys, your answer is going to with the expectant management. You admit the patient, you arrange the blood. If RH negative, give anti-D, guys, and steroid for the lung maturity. Okay, I mentioned, guys, the beta methazone 2 doses, guys, 12 into 12, total of 24 mg. Dexamethasone, guys, 4D4 6 total of 24 mg. And how do you check this fetal lung maturity? By checking the phosphatidylglycerol in the amniotic fluid. One more condition, guys, we have lecithin and sphingomyelin ratio. These are the indicators of the fetal lung maturity. And if you have a patient having a low-lying placenta, guys, you will go for the trial of normal vaginal delivery. And if you have a posterior low-lying, guys, check for the fetal heart rate, guys. If it's less than 100, you go with a cesarean section because it has increased chances of cord entanglement. So main point it is here, guys, more than 37 weeks cesarean section, less than expectant management. Conditions apply. If a baby is coming into the distress at that time, obviously you have to save the baby, guys. Cesarean section. Is it clear, guys? So what will be your answer here, guys? Your answer is immediate cesarean section. She is a 37 weeks, guys, term plus central or complete placenta previa, immediate LSCS. Is it clear? Placenta previa very important, guys. One question to aayega hi aayega. One question can be asked from the placenta previa. Management, don't remember the causes, don't remember this, what is central, what is low lying, you know. Just remember painless bleeding, placenta previa, at term, at preterm. What will be the management? So they will ask the management. Don't focus on these causes, sites and all. Focus on what? Management. What is the next management and what is the best management? For example, low-lying placenta, guys. What is the next management? You have to go for trial of normal vaginal delivery first. All clear, everyone? Can we go to the next question, guys? Can we go to the next question? Yes, sir. Chalo. A 27-year-old woman with a recent abdominal cramps, a vaginal bleeding and 3 months amenorrhea goes to the emergency room. So our patient is coming, guys, 27-year-old. She's 3 months amenorrhea, guys. She's 3 months pregnant and she's coming and complaining of an abdominal cramps and bleeding per vaginal. She has bleeding. Upon the examination, guys, cervix is open with the products felt. The uterus is a size of a 10-week pregnancy. That means the period of gestation, it doesn't correspond to the size. Okay. And there is a bleeding from the cervical opening. What is a likely diagnosis? So what is your likely diagnosis? So it is a case of an abortion. It's a case of a abortion. Now let's discuss a different types of abortion and what are the presentations of different types of abortion. Always remember, guys, you have to focus whether the os is closed or the os is open. Number one thing. Number second thing, guys, you have to focus. Number second thing, you have to focus whether a patient is giving a history of a bleeding or not. Third thing, you have to see whether a uterine size is corresponding to the period of gestation. Is it smaller or is it larger? Is it clear, guys? So let's discuss different types of abortion. So what is the presentation of abortion, guys? Patient is having amenorrhea, patient is pregnant, patient is having a pain and bleeding. Pain and bleeding. Okay. Now, first of all, guys, on PV examination, on per vaginal examination, okay, if, my dear students, os is closed and a uterine size is equal to the period of gestation, that means if she is 15 weeks pregnant, okay, and uterine size is also 15 weeks, so that means both are equal, nothing is wrong. Okay, os is closed, door is closed, uterine size is corresponding to the period of gestation. It is a type abortion called as threatened abortion. क्या होगा? Threatened abortion. So what you will advise the patient, don't worry, you just take a rest and progesterone. Okay, bed rest and progesterone, you will manage the patient. Okay, now if the os is open, very important, guys, first of all focus on the os. If the os is open and products are bulging, products are bulging, okay, products are bulging, hanging, coming out, clots, okay, such type of abortion is called as inevitable abortion. Such type of abortion is called as inevitable abortion. Okay, then third one, guys, if the os is open, products are felt with the history of passage of some masses. Products are felt. Patient will give a history that she has passed some clots, okay, with the history of passage of some masses, or clots. Your answer will go to the incomplete abortion. That means incomplete abortion. If the os is closed, history of passage, patient will give that I had passed a big clots, history of passage, and then your uterine size is normal. There is a normal uterine size, non-pregnant uterine size. That means it is a type of a complete abortion. Okay, and if the os is closed, okay, there are no warning signs, no bleeding, no pain, no warning signs or symptoms sometimes. Okay, no warning sign or symptoms. Okay, there is a crumpled sac or a fleshy mass seen. There is a crumpled sac. Such type of abortion is called as missed abortion. क्या बोलेंगे इसको guys? Missed abortion. So simple way, guys, os is closed, uterine size is equal to the period of gestation, threatened abortion, nothing is wrong. Okay, os is open, products are bulging, you go with the inevitable abortion. Okay, os is open, products are felt, and the patient is giving you a history of passage of masses, you go with the incomplete abortion. Os is closed, history of passage, that means whatever it was inside, guys, clots have passed, now the os is closed, patient is having a normal uterine size, you go with the complete abortion. And if there is a crumpled sac inside with a no warning sign and symptoms, on PV examination os is closed, that is your missed abortion. So here, guys, upon examination, guys, the cervix is open, products are felt, the uterus is a size of 10 week, and there is bleeding from the cervical opening. Okay, guys, and there is a bleeding from the cervical opening. What will be your diagnosis, guys? What will be your diagnosis? Comment down your answers. What will be your diagnosis? Yes, patient is not giving any history of what? Passage. Okay, but your products are bulging. While doing the PV, you are seeing products are bulging, you are feeling the products are bulging, that goes with the inevitable abortion. In incomplete abortion, patient will give the history, it will be mentioned she had already passed some what? Masses. Is it clear, guys? Is it clear? So your answer goes to inevitable abortion. Okay, so most second trimester abortion causes, guys, we have already discussed that it can be subtate uterus, it can be a bicornuate uterus, or incompetent cervix. First trimester, chromosomal. Okay, then recurrent pregnancy loss, the question is coming on the antiphospholipid antibody syndrome, that we are going to discuss shortly. Chalo, guys, next question. So remember, guys, PV examination, guys, and then what can be the drugs for this abortion, we'll discuss, guys. What is the time for medical abortion, then what time will go for evacuation, curettage, and prostaglandin. So I will discuss that in a further questions. Next question. A 19-year-old girl comes with a 3 months amenorrhea. She's having an excessive vomiting. Blood pressure is 110/70 on per abdominal examination. Your fundal height is 18 weeks. Doctor advised the USG report and it showed, this is a classical image that is given. What will be your management? So what is an appearance on the USG, guys? So it is a snowstorm appearance. It is a snowstorm appearance on USG. Okay, and snowstorm appearance, or the another name for this appearance, okay, what is the another, guys? Cluster of grapes appearance. Cluster of grapes appearance. Okay, and this cluster of grapes appearance, it is classically seen in which condition, guys? Your diagnosis is high dative form mole or molar pregnancy. Your diagnosis is molar pregnancy. Then in a molar pregnancy we have complete mole and incomplete. In complete, guys, we have type 1 in which endoduplication occurs, guys. Okay, and a classical picture of snowstorm appearance is seen in complete molar pregnancy. Now, guys, molar pregnancy, I've already discussed the appearances. Now what is a type 1 complete mole? Type 1 complete mole. Okay, so what happened, guys? It's also called as vesicular mole, and endoduplication occurs in type 1 mole. Endoduplication occurs. What is endoduplication occurs, guys? If it's 23x, it becomes by itself 46. Okay, so that is endoduplication occurs. Okay, main part is a management of this mole. Main part is a management. Okay, so what is the management, guys? We go for suction and evacuation. We go for suction and evacuation. So patient will come with a hyperemesis. Why? Because there is increased beta HCG here. Okay, there is increased beta HCG, and you already know, guys, increased beta HCG causes hyperemesis. So patient is coming of what? Complaining of what? Excessive vomiting. Okay, that's why there is a hyperemesis. Then patient can complain of what? Thyrotoxicosis as well. Okay, and patient have a bleeding. Beta HCG is increased. Okay, on USG, guys, so many hints on USG. There is a snowstorm appearance. So molar pregnancy. So how do you manage this, guys? You will go for suction and evacuation. You will go for suction and evacuation, followed by slow curettage. Followed by slow curettage. Okay, then after that, guys, you will do USG to check a retained beds. To check a retained beds, because they can cause a complication, they can cause an infection. Okay, so you will do USG to check the retained beds. Okay, then you will do chest x-ray, because this molar pregnancy, guys, okay, if it metastasizes to lungs, there is a classical appearance of the lungs called as cannonball metastasis. Okay, so this was a picture, guys. It was asked before as well. Cannonball metastasis. This is cannonball metastasis. Okay, cannonball metastasis. So we will do chest x-ray to rule out lung metastasis. To rule out lung metastasis. Okay, this is cannonball appearance. This is cannonball appearance. Okay, and then, guys, you have to follow up. This was the question asked, that follow up for HCG for how many months, guys? You have to follow up HCG till 6 months. You have to follow the HCG till 6 months. So what is the management, guys? Suction and evacuation, slow curettage. After that, you will do USG to check the retained bits. Okay, then you will do chest x-ray to rule out the lung metastasis. The classical picture of a cannonball metastasis is a PYQ again, and you have to follow up a beta HCG for 6 months. So here, what will be the management, guys? Your management will be suction and evacuation. Your management is suction and evacuation. Is it clear, guys? Everyone, is it clear, guys? Molar pregnancy समझ आ गया? Molar pregnancy understood, guys? Yes, everyone. Your answer is suction and evacuation. Your answer is going to be suction and evacuation. Next question. A 35-year-old lady a 35-year-old lady, gravida 3, para 2, live 2, at 36 weeks of pregnancy. She's in the 36 weeks of pregnancy and she was admitted in a labor room with a blood pressure of 150 by 100. Okay, that means already she's having what? Pregnancy induced hypertension and high blood pressure with the labor pains. After 4 hours, she was complaining to have a severe pain abdomen in between the uterine contractions. The uterus is 36 weeks. Okay, that means uterine size is corresponding to the period of gestation. She's having a tenderness, guys. Fetal heart rate is 100. PV cervix was 4 centimeter dilated. Membrane ruptured, showed a blood stained liquor. That means there is a red color amniotic fluid, and red color amniotic fluid is a classical hint. For what? Antepartum hemorrhage. I have discussed in the types of a amniotic fluid and a stained amniotic fluid. For example, if it is a green color, it's meconium stain. If it is a golden yellow color, it is RH incompatibility. If it is a tobacco juice color, it's an intrauterine death. And if it is a red color, that is antepartum hemorrhage. Straw color, guys, normal amniotic fluid. So different colors of a amniotic fluid. So here it's a blood stained liquor. So red amniotic fluid, your classical diagnosis of a antepartum hemorrhage. Then in antepartum hemorrhage, guys, it is giving you a hint of pain abdomen. It is a tenderness, pain abdomen, okay, and blood pressure is increased. So your diagnosis is abruptio placenta. Now let's discuss this abruptio placenta. Your diagnosis is abruptio placenta. Now, my dear students, when I discussed this abruptio placenta before, guys, see, she was prepared for LSCS. On doing laparotomy, this was the uterus. All are to be done except. Now, this type of uterus, it is seen in abruptio placenta. It's called as bruised uterus due to the trauma. It's a bruised uterus, or it is called covulate uterus. It is also called covulate uterus or bruised uterus, which is seen in which condition, guys? Abruptio placenta. It is seen in abruptio placenta. Now, guys, what are the two causes of abruptio placenta, guys? It is increased blood pressure and trauma. Then see what are the hints given. Increased blood pressure, tender, bleeding, blood stained amniotic fluid. So all the hints are given to the abruptio placenta image as well. So what will be the steps that are to be done? Except complete the LSCS, give oxytocin, and after the placental delivery the placenta by control cord traction or the Brand-Andrews method. I've already discussed what is a Brand-Andrews or a control cord traction, guys. You take the cord and slowly move the cord so that the placenta will be separated from the uterus, guys. So there will be no postpartum hemorrhage. Okay, so it's because control cord traction is a classical step of what? Active management of the third stage of the labor. Okay, then the next one, to do hysterectomy. Okay, so let's discuss the management first. Okay, now if you have a patient coming to you abruptio placenta at term. Okay, at term, what is abruptio placenta, guys? Sudden separation of a placenta, or premature separation of the placenta, Now this abruptio placenta, my dear students, it can be of two types. One is concealed, another is revealed. Concealed and revealed. So what is concealed and what is revealed? Okay, revealed is when the bleeding will come out. Okay, when it will escape the membranes. Concealed is when the bleeding is intact between the placenta and the uterus, between the membranes, so the bleeding is not coming out. Okay, I'll show you the picture so that you can understand exactly what it means. See, guys, see, in concealed abruption, see, can you see between, this is the placenta and uterus, between there is a blood. Okay, and blood cannot escape the membrane, so it's a concealed abruption. But here the blood is escaping and blood is coming out. It is a revealed abruption. So concealed and revealed abruption, concealed and revealed abruption. Further, guys, what do I mean by abruptio placenta? It is a premature separation of a normally implanted placenta, which is usually associated with high blood pressure. Okay, it's usually associated with high blood pressure. The presentation of the patient: painful bleeding and tender uterus. Okay, all the hints given. Now if a patient of abruptio placenta to you is coming at term, what is your management, guys? At term you will go with the normal vaginal delivery. Yes sir, normal vaginal delivery with artificial rupture of membrane. So right arm, yeah, it's not your arm, it's artificial rupture of membrane. So remember this, okay? Artificial rupture of membranes. Why? Because currently, is she having any contraction? No, she was just normal premature, 35 weeks, 37 weeks, okay, no contractions present. But for contractions, we need contractions. For that we need prostaglandins. So when we rupture this artificial rupture, when we rupture these membranes, they will release endogenous prostaglandin, which will induce the labor, induction of labor by artificial rupture of membranes. What do I mean by augmentation, guys? In augmentation, contractions are present, but they need enhancement. So here, what are we doing exactly, guys? Induction of labor when there are no contractions and we are starting the contractions. So guys, patient coming to you in a term having an abruptio placenta, your answer is going to be normal vaginal delivery with the artificial rupture of membranes. So what will these artificial rupture of membranes do? They will release prostaglandin. And yesterday, prostaglandin, kal to padha hi hai, guys. You have yesterday when I talked about an arachidonic acid pathway. After the tissue injury, guys, when there is a tissue injury, arachidonic acid is released, and then we'll have a cyclooxygenase and lipoxygenase pathway. COX will give us a prostaglandins, which causes a dilation, you know, guys. So release prostaglandins, okay, they will induce the labor, which will induce the labor, okay guys, and then give the oxytocin and deliver the baby. If at term fetal heart rate is less than 100 in abruptio placenta, you will go with the cesarean section. क्या करोगे guys? Cesarean section. Now if in preterm, then again an expectant management, okay? Admit the patient, guys, give steroids. If RH negative, give anti-D, oxytocin and deliver the baby. Is it clear, guys? So main at term, normal vaginal delivery with artificial rupture of membranes, because with artificial rupture of membrane is important, because normal vaginal delivery all of a sudden you cannot do when there are no contractions, okay? For that's why we are inducing the labor with the help of an artificial rupture of membrane. Is it clear, guys? Abruptio placenta. Now tell me, guys, yes, we'll complete the LSCS. Okay, we can go for the LSCS if a fetal heart rate is decreased. Yes. Do we give oxytocin after the placental delivery? Yes, to prevent a PPH. Delivery placenta by control contraction? Yes. Do hysterectomy? No, there is no hysterectomy in case of abruptio placenta. Is it clear to everyone, guys? Is this clear to everyone? No. Is it clear to everyone? There is no hysterectomy in case of abruptio placenta. Write down in the comment section, guys. All clear? Yes. Chalo, guys. Next question. A 28-year-old primary gravida has delivered a baby. Placenta is still intact. In case the nurse forcibly extract the placenta, that means a sudden contraction of the placenta, which complication is likely to occur? Which complication is likely to occur? Okay, a 28-year-old primary gravida, guys, she delivered a baby, and if a nurse is forcibly extracting the placenta, what will happen, my dear students? What will happen? Uterine inversion, acute inversion of a uterus, acute inversion of a uterus. Sir, any one of the above? Yes, PPH can also happen, but yes, sudden contraction, your main best choice will be uterine inversion. So what will happen, guys? Uterine inversion. If I'll show you a classical image of the uterine inversion, guys, uterine inversion, yes, uterus is coming out, but there is a turning upside down of the uterus. So the upper part, guys, this is the upper part inside, it will come just like this out, okay? So that is a uterine inversion. What is uterine prolapse, guys? Uterus is descending down like this. Okay, but what is uterine inversion? Top of the uterus coming out, becoming down of the uterus. Okay guys, bottom of the uterus. So I'll show you the picture, guys, of uterine inversion. See, this is a classical picture of a uterine inversion. Okay, the uterus has come out. Now what can be the reason of this uterus when it is coming out? So let's discuss that. What exactly is uterine inversion? So it is a turning inside out of the fundus into the uterine cavity. Into the uterine cavity. That is a uterine inversion. Now what can be the causes of this uterine inversion, guys? First of all, sudden cord traction. That's why if you move suddenly, if you take the cord and take out the placenta suddenly, what will happen? The uterus will come out, uterine inversion. That's why in an active management of third stage of labor, what is mentioned? You have to go for controlled cord traction, slowly, controlled cord traction. So write it down, guys. First reason, sudden cord traction. Sudden cord traction. Number second, guys, we have badly adherent placenta. We have badly adherent placenta. What do I mean by adherent placenta? Okay guys, so normal conditions, we have a neta bush layer present. Okay guys, which layer? Neta bush layer. It is a fibrinoid layer which helps in a smooth separation of a placenta. Now if this fibrinoid layer is absent, okay guys, if there is an absence of this neta bush layer or the fibrinoid layer, what is your diagnosis? Sir, it is an adherent placenta. Then after, depending upon the invasion, so first I will write, guys, absence of neta bush layer. There is the absence of neta bush layer. Okay, now this absence of neta bush layer, absence of neta bush layer, it will cause a adherent placenta. Three types. क्या कहोगे guys? Accreta, increta, parcreta. So placenta increta, placenta accreta, and placenta parcreta. Now depending upon the invasion of this placenta, now this layer is absent, guys. Let me show you the classical picture, guys. Now see, this layer is absent. Okay, it's a normal placenta. Now accreta, guys, it is going till the myometrium. Increta, guys, it is invading a serosa. Parcreta, guys, it is invading what? It is invading up till uterine muscle. It's invading up till uterine muscle. So increta, accreta, parcreta, depending upon the invasion. See, it's normally, guys, the neta bush layer is present. When the neta bush layer is absent, this accreta enters into the myometrium, then to the serosa, increta, and then to the uterine muscle. Uterus mein ghus jata hai, guys. That is parcreta. Now when I will try to take this placenta out, can you see the picture, guys? I will try to take this placenta out. Will it be easy for a placenta to come out or a difficult? Yes, it will be a difficult to come to deliver the placenta. And when you will try to force, what will come? Rather than a placenta, whole uterus will come out. So there's a turning inside out of the fundus. Okay guys, and such condition is a uterine inversion. Now did you understand what is this, guys? This is a adherent placenta. See, this is a adherent placenta. When the uterus is when the placenta is invading what? Myometrium, serosa, and a uterine muscle. Is it clear, guys? And when this layer is absent, which layer? Neta bush layer, we call them what? We call it as a adherent placenta. What will be your management then? Obstetric hysterectomy. Your answer is obstetric hysterectomy. But most of the times, guys, it depends upon the invasion. It depends upon a invasion, whether there is a less invasion or more invasion of a placenta into the muscle. Is it clear, guys? Into the uterus. So badly adherent placenta, absence of a neta bush layer. Okay, now the placenta is out. This was a question asked in the previous exam. Now the placenta is out, guys. Patient will go immediately into the shock. Okay, after a patient is having what? pph, and if there is a uterine inversion, patient will immediately go into the neurogenic shock followed by a hemorrhagic shock. But the most common cause of death in case of an uterine inversion, your answer is going to be a hemorrhagic shock. Now a patient is having a uterine inversion. What is your first management? Your first management, write it down guys. Resuscitation to karoge hi. Management, manual reposition of a uterus. You will go with the manual reposition of uterus. Okay, the maneuver that we use for manual reposition of the uterus, okay, manual, put the thumb, fist it in. The part which came the last, it will go the first. जो last में निकला था बाहर, वो सबसे पहले अंदर जाएगा. With the fist, you will push this uterus back. Such a maneuver is called as Johnson's maneuver. क्या बोलते हैं बच्चों? Johnson's maneuver. Then with the help of a hydrostatic, with the help of a normal saline, you put forcibly inside the uterus and push this uterus back into the normal position. That is called as hydrostatic reposition. Full pressure, hydrostatic water, hydrostatic reposition of the uterus. Such a method is called as O'Sullivan method. O'Sullivan method. Okay, and then my dear students, the most common cause of death in uterine inversion, your answer goes to hemorrhagic shock. Your answer goes to hemorrhagic. First it will go into neurogenic shock followed by hemorrhagic shock, but your classical answer for death reason will be hemorrhagic shock. Okay, in a question given of a uterine inversion, they will mention patient is given first management IV access here. Don't worry, IV access you will always give, okay, in such conditions, because patient is bleeding shock हो रहा है, तो give IV access both the lines, secure the line by 18 gauge. Okay, remember one more condition guys here, what I was saying, surgical procedures, surgery for this, we have two surgeries guys. If surgery for the uterine inversion, we have Huntington and Holtian procedures. Okay, and one more condition from the uterine inversion, very important, a classical case will be given and they will mention a patient went immediately into the shock. They will mention a patient went immediately into shock. So patient having immediately a shock, your diagnosis is uterine inversion. So after delivery, patient goes into the shock, postpartum hemorrhage, immediately goes into the shock, uterine inversion. Patient goes in an unexplained shock like hypotension, hypoxia and coagulopathy, triad is given. Your classical case is amniotic fluid embolism. So here guys, what will be the condition if a patient is, if the nurse is trying to extract the forcibly the placenta, sudden contraction will happen. What will happen guys? Acute inversion of the uterus. Okay, it is also seen in the fundal implantation of the placenta, tab bhi hota hai uterine inversion. So your answer is uterine inversion. So remember the picture as well guys. So everything I've cleared, nothing new more from this guys. Uterine inversion. Okay, badly adherent placenta, Huntington and Holtian procedure is the surgical methods. So let's move to the next question. Drugs for medical abortion. Drugs for medical abortion. Mifepristone 200 mg, methotrexate after 48 hours. Misoprostol 200 mg, methotrexate after 24 hours. Mifepristone 200 mg, misoprostol 800 micrograms. Misoprostol 200 mg and mifepristone 400 micrograms. Now let's discuss this question guys. Now the drugs for medical abortion. So remember that the medical abortion, if done in first 7 weeks, it is 99% successful. If I talk about medical abortion guys, surgical to baad mein, medical abortion and surgical. Medical when you give medications like misoprostol, mifepristone, hai na? Surgical abortion when you go for the dilatation and evacuation, dilatation and curettage, suction and evacuation, or the prostaglandins later on. Okay, first medical abortion. Now in medical abortion guys, write it down, 99%, it's 99% successful if done within first 7 weeks. If done within 7 weeks, and it's 95% successful if done within 9 weeks. If done within 9 weeks. Okay, after that guys, the drugs the drugs that you will give, first of all guys, we will give टैब मिफिप्रिस्टोन, क्या देंगे? टैब मिफिप्रिस्टोन। कितना दोगे मिफिप्रिस्टोन गाइस? It is, what is a mifepristone? First, it is an anti-progestin. It is an anti-progestin. So what will this mifepristone do guys? It will kill the fetus. This mifepristone will kill the fetus. After this mifepristone will kill the fetus, what will be the dosage guys? 200 to 600 mg. 200 to 600 mg. Then you will give the next drug, tab misoprostol. Now after the fetus is killed guys, fetus is dead, now you need to expel this fetus out, so you'll give tab misoprostol, which is a prostaglandin. Okay, tab misoprostol. Now which class of prostaglandin guys? It is prostaglandin E1. It is prostaglandin E1, will give vaginally. Okay, we also use these drugs guys for an induction of a labor. Okay, we need to expel the baby out, induce the labor. Okay, at that time we use misoprostol 25 micrograms, we directly put into the vagina guys, so that the patient will have what? Induction of the labor, and she will deliver the baby, है ना? PGE1. Okay, and what is the function guys? It will expel the fetus out. It will expel the fetus out. It will expel the fetus out. And how much to give guys? 800 micrograms. कितने देते? 800 micrograms. So it is a medical abortion. Mifepristone, that will kill the fetus. It's an anti-progestin. Misoprostol, that will expel the fetus out, which is a prostaglandin. Okay, now what will be your answer guys? It will give mifepristone 200 mg guys, followed by misoprostol after 48 hours. So first they will kill the baby guys, then there will be a bleeding, followed by that they will give misoprostol. So remember 200 mg, 800. Now dose of the misoprostol guys, it depends upon a, it can be given rectally, buccal, orally, vaginally. So 800 micrograms vaginally. Is it clear guys? Medical abortion, and it's 99% successful if given in 7 weeks, and it's 95% successful if given in 9 weeks. Further, next question. Now let's discuss next question. Is it clear guys? Write down in the comment section guys. Wake up. Yes, all clear? All clear guys? Okay, good. Chalo guys, next question. A 25-year-old primary gravida presents with a lower abdominal pain and vaginal spotting. On palpitation, tenderness is noted. Urine pregnancy test was positive, and the beta HCG level is 1500 international units. On USG performed, there is no double decidual sign. That means no double decidual sign. It's a classical case of what? Ectopic pregnancy. But also one more hint, adnexal mass was noted. So she's already a diagnosis of what? Ectopic pregnancy. What will be the most appropriate next step in the management of this patient? Okay guys, what is your diagnosis bacho? Your diagnosis is, it's already given, there is no double decidual sign. That means it is ectopic pregnancy. We have already discussed ectopic pregnancy 5 times in part 1 and part 2. Now let me tell you a fast ectopic pregnancy guys. You already know most common site of ectopic pregnancy is fallopian tube. I'll discuss this faster guys. Most common is fallopian tube. And which part of a fallopian tube mainly guys? Ampulla. And the most common cause of this ectopic pregnancy, it is mainly infections. There can be other causes like progesterone only pills, genital TB, endometriosis, and use of intrauterine contraceptive devices. So that can be other causes as well. So you remember guys, most common cause is PID, salpingide systemic nodosa, PID, whether that causes chlamydia or gonorrhea, depending upon whether it is symptomatic or asymptomatic. PID udhar nahi jaunga main. Now let's discuss a management. Okay guys, let's discuss a management. If it is a ruptured ectopic pregnancy, guys, that means she's will be in the shock, hemodynamically unstable. In a hint will be given. You have only one surgery guys, salpingectomy. Kya karoge? Salpingectomy. If it is unruptured, my dear students, you have 2 scenarios. Either you will go with the medical management, either you will go with the surgical management. When you will go medical, when you will go to the surgical. if a beta HCG is less than 5000 international units, okay, and ectopic size is ectopic size is beta HCG is less than 5000, ectopic size is less than 3.5 centimeter, you go with the medical management. What can be the drugs? You can use misoprostol, you can use mifepristone, actinomycin, KCL, okay, and methotrexate. Okay, mifepristone, methotrexate, actinomycin, and KCL, these four drugs. Okay, so if it is more than, if HCG is more than 5000 international units and ectopic mass size is more than 3.5 centimeter, you go with the surgical management. Okay, so I will write in the medical management, you can use methotrexate, you can use KCL, you can use actinomycin, you can use mifepristone. Okay, these are the medical management drugs. And in surgical management क्या क्या करोगे guys? You can go with the salpingostomy. You can go with a salpingostomy. You can go with the salpingotomy. You can go milking of tube or resection anastomosis. This will be your surgical procedure. Now my dear students, medical surgical समझ आ गया, management एक topic का. Now further how to diagnose this ectopic pregnancy based upon the investigations. If beta HCG it is doubling in 48 hours, if it is doubling in 48 hours, my dear students, your answer will go to the intrauterine pregnancy. Your answer is intrauterine pregnancy. If it is doubling in 5 to 7 days, okay, if it is doubling in 5 to 7 days, your answer is going to be ectopic pregnancy. Your answer is ectopic pregnancy. Then if double decidual sign present, it is intrauterine pregnancy. If double decidual sign absent, it is ectopic pregnancy. So here beta HCG is 1500, less than 5000. You will not repeat guys, because already there is no double decidual sign. Number one thing. Number second thing guys, you cannot continue the pregnancy. It will rupture the tube once the size will increase. You cannot go for the surgical management as the beta HCG is less than 5000. Your answer will be single dose methotrexate. क्या करोगे guys? Single dose methotrexate. Is it clear guys? Everyone clear हो गया? Everyone all clear? Yes sir. All of you over there, is this clear? Chalo, no time, we have to finish. A pregnant female presented to the emergency with the complaints of abdominal pain and vaginal bleeding. On examination, the cervical os was closed and there is no prolapse of the products. The fundal height, that is a hint guys, fundal height is corresponding to the gestational age. What is your likely diagnosis? Answer me. I've just taught you this 5 minutes back. I've just taught you all the abortion and the presentation. Now I'm saying a os is closed, period of gestation is equal to the uterine size. Okay, so if it is like 15 weeks pregnant, period of uterine size is also 15 weeks. So 15 equal to 15. Which type of abortion? Os is closed. Which type of abortion? Write down in the comment section faster. What will be your answer, my dear students? What will be your answer? Write down all the people. Hanji bachcho. What will be your answer? Os is closed. Uterine size is equal to the period of gestation. There is no prolapse of products. कुछ भी नहीं निकला, सब कुछ सही है. Sir, it is a type of abortion called as threatened abortion. Okay guys, it is a threatened abortion. Okay, what will be your management for threatened abortion guys? You will tell patient take the bed rest plus give progesterone. Bed rest and progesterone. It is a threatened abortion. See guys, just now we studied this types of abortion here. ये देखो, uterine size, uterine size is equal to the period of gestation. Uterine size is corresponding the period of gestation. Your answer goes to threatened abortion. Os is closed, uterine size is equal to period of gestation. Your answer is threatened abortion. Bed rest plus, bed rest plus. Chalo, next question, progesterone. A lady suffering from the diabetes mellitus delivered at term. Okay, she delivered at term. An infant of a diabetic mother is at the risk of all of the following except. Okay, he's at the risk of all of the following except. Okay, guys, you already know, guys, hyperbilirubinemia occurs. Yes, there is a caudal regression syndrome, which is also called as sacral agenesis, which is also called as sacral agenesis, which is a neural tube defect associated. After that, guys, the fetal lung of a baby born to the diabetic mother, usually fetal lung is maturity is delayed in case of a JDM. So there is a fetal distress syndrome associated as well, but there is no hyperglycemia. Rather, my dear students, वहाँ पे क्या होता है? There is hypoglycemia. Now let's discuss this JDM थोड़ा बहुत. Okay, guys, we have already discussed in the part 1, part 2, but यहाँ पे let's discuss. So infant of a JDM, gestational diabetes mother, gestational diabetic mother, guys, he will have hypoglycemia. क्या होगा उसको, guys? Hypoglycemia. What is the reason of this hypoglycemia, guys? It is due to the beta cell hyperplasia. So beta cells of pancreas, there is a hyperplasia. That's why baby will have what? Hypoglycemia. After that, guys, the most common neural tube defect, the most common neural tube defect associated with GDM, your answer goes to sacral agenesis. Your answer goes to the sacral agenesis, which is also known as, it is also known as caudal regression syndrome. It is also known as caudal regression syndrome. Okay, most common cardiac defect, most common cardiac defect, your answer goes to the transposition of great arteries having a agon string appearance. After that, guys, also we have VSD and all, also we have VSD, but most common will be transposition of great arteries. Okay, now this diabetes GDM, okay, which two hormones are responsible, guys? Human placental lactogen and estrogen. They have an insulinase like action, okay, which will cause resistance and increase the blood sugar levels more than 24 weeks. So GDM occurs more than 24 weeks. Okay, if before, okay, if already she is having a diabetes, we call that overt diabetes mellitus. So remember, guys, congenital anomalies are associated with overt diabetes, not with a gestational diabetes. So there is a macrosomic baby as well. So what is macrosomic baby? More than 4 kg. When there is a macrosomic baby, there is increased chances of a shoulder dystocia. When there is shoulder dystocia, there is increased chances of giving episiotomy if you go for the normal vaginal delivery. So what is the maneuver for shoulder dystocia? We have Mac Roberts maneuver. कौन सा maneuver है, guys? We have Mac Roberts maneuver. We have other maneuvers, but mainly you remember Mac Roberts maneuver. What is your drug of choice? Drug क्या दोगे इन यहाँ पे? What is your drug of choice for GDM? Drug of choice for GDM, you will give, my dear students, insulin is a drug of choice. But if asked oral hypoglycemics, orally you will give metformin, which is a class of a drug called, which belongs to the class of a drug called as biguanides, and you will give glyburide, which is a drug belongs to the class called as sulfonylureas, having a side effect of hypoglycemia, while as metformin, biguanides have a side effect called as lactic acidosis. So it was all about gestational diabetes mellitus. इतना याद रखो GDM के बारे में, that is more than enough. इतना याद रखो, more than enough. Everything is increased. There is polycythemia in a baby, okay, there is hypermagnesemia in the baby, okay, there is hyperbilirubinemia, but remember, guys, there is hypoglycemia due to the hyperplasia of beta pancreatic cells. Chalo, guys, next question. Is it clear, all of you? Is it clear to everyone? Yes? Write down in the comment section, guys. Follow by curettage, incomplete. Very good. I'm checking your comments. Good. All clear, guys? Hypoglycemia. Very good. All clear? Everyone out there? Yes. Are you understanding, guys? Speed is okay? I'm a little bit faster. You can watch the video later on as well at 2x speed. But we have discussed most of these conditions in the part 1 and part 2. Chalo, guys. Next question. Okay. A 30-year-old primary attends an antenatal clinic at the period of amenorrhea 35 weeks. So she's a 35 weeks lady coming to a ANC checkup. She has a single fetus in the breech presentation. So what is presentation, guys? A presentation means which part of a fetus is lying into the cervical os. Okay, touching part lower segment, it is a presentation. So if a shoulder is touching, you will call it as shoulder presentation. If the head is touching, you will call it as a cephalic presentation. If a sacrum is touching, you will call it as a breech presentation. Now based upon that, we have a different types of breech. We have frank, we have complete, footling and all. Okay, so breech presentation is coming. Ultrasound scan presentation confirmed. No other abnormalities are detected. What is the next step in the management of the normal vaginal delivery? Now if you want to deliver this breech presentation in a normal vaginal delivery, by a normal vaginal delivery, so what will be your first step? Now remember, guys, if breech presentation, breech in transverse lie, if a breech in transverse lie will come in labor में आएगा, क्या करोगे? Cesarean section. If a breech presentation is coming to you in labor with a transverse lie, I'm saying with a transverse lie, you will go with the cesarean section. Now guys, remember, if not in labor, okay, she's coming to you at 32 to 34 weeks. Okay, she's coming to 34 weeks. What you will do to this baby, guys? Wait and watch. Why, sir? Why we will wait and watch? Because she's not in labor. She's a breech presentation coming to you 32 34 weeks, because amniotic fluid keeps increasing. Because the amniotic fluid keeps increasing by 32 to 34 weeks. And even if you will change if you go for the external cephalic version, you are trying to move the baby, but when the amniotic fluid is more, baby will change its prior position. Okay, so what you will do, you will wait till 36 weeks. So write it down, guys. At 36 weeks, amniotic fluid is decreased. Okay, and we will go for external cephalic version. So you will move the baby, guys. You'll go for external cephalic version as the amniotic fluid start decreasing after 36 weeks. So the baby will not change its position. From transverse lie, we can make it to the vertical and deliver normal vaginal delivery. So ECV is done. External cephalic breech can be transverse or vertical. Okay, Mansoor Malik. Breech, I mentioned breech in transverse. If a breech is in the transverse lie, then in labor you go with the cesarean section. Okay, guys, because baby can change its position from vertical to the transverse. Okay, baby keep dancing inside when the amniotic fluid is more. Baby can be in any position. Okay, guys, so if that's what I mentioned, breech in transverse lie. Okay, if vertical lie, then you will deliver this breech with the help of a maneuvers. For extended arms, you will have a Pinard's. For extended arms, you have a Lausset's maneuver. For extended arms, you will have a Pinard's maneuver. Legs Pinard's maneuver, arms, Lausset's maneuver. After coming the head, you will go with the Bern-Marshall technique or the Retigen maneuver, or you will use the forceps after coming the head, called as Piper's forceps. Okay, so that is how you deliver breech in a normal vaginal delivery when it has a vertical lie. But this breech can be a transverse lie also. At that time, if a patient is coming to you in a labor, you will go with a cesarean section. And if she is not in labor, if the transverse lie, now this transverse lie can be shoulder presentation also or breech presentation also. Okay, so for a normal vaginal delivery, what we are doing, guys, we are going with the external cephalic version. That's what is mentioned in the question as well. Why? If it would have been in cephalic, okay guys, okay, if it would have been in cephalic, so what I would, why the question would have mentioned normal vaginal delivery, then breech you have delivered normally. Okay, so breech for a transverse lie, to change it into the cephalic, guys, you have to go for external cephalic version. And what you have to keep in consideration, guys, amniotic fluid levels. Okay, so amniotic fluid is peak at the 32 to 34 weeks, expected to be 1000 ml, and after that, guys, by 36-37 weeks it's said to be 600 ml, and then it keeps decreasing. That's why the classical reason of a oligohydramnios, that means a decreased amniotic fluid, is post-term and the post-dated pregnancy. Is it clear, guys? So what you will do at 32-34 weeks, you will wait. Okay, if she's not in labor, you will wait. Okay, if in labor, cesarean section. And why you are waiting, guys? Because the amniotic fluid keeps increasing. So at 37 weeks, amniotic fluid is decreased, you will go with the ECV. You can also go for internal podalic version, but my dear students, there are contraindications, because the forceps, the instruments, they can cause a rupture of the uterus. Already it's transverse life, and when you will put the instruments, that can cause what? A rupture of the uterus. ECV, and twins may be contraindicated. So what is your answer here, guys? So what you will do, you will perform a external cephalic version at 36 weeks. Can you go for artificial rupture of membranes? No. Even if you go for artificial rupture of membranes, there will be a dilatation, but it's a transverse. It's a transverse presentation. Okay, perform an elective cesarean at 39 weeks. Why you will go for cesarean section? You can your first choice is you have to go for an external cephalic version, and 41 weeks there are the later on options. You have to choose the first one. So you will perform an external cephalic version at 36 weeks. Okay, then breech presentation, my dear students, we can have a different types. Most common is your frank breech. Then you can have an incomplete breech or a complete breech. Then you have a footling breech. So footling breech is the one you have to deliver cesarean section. Okay, and then the maneuvers that we use for this frank breech, when you deliver this normal vaginal delivery, for extended legs there is a Pinard's maneuver. For extended arms, there is a Lausset's maneuver. For head there is a Retigen maneuver, Piper forceps. Okay, and Bern-Marshall technique. Okay, that's what is mentioned. I will show you the types of breech. We have a stargazing sign in case of a frank breech. Leave that part, you just remember this much. Okay, so this is a frank breech, guys, complete and footling breech. Flex breech, normally, extended normally. Footling, you have to go with the cesarean section. Okay, best type is a frank breech, guys. Remember, guys, after coming the head, you have go with the Piper forceps, Bern-Marshall technique, and this maneuver, it is a Retigen's maneuver. Okay, and jaw flexion and the shoulder traction technique, which is known as Mauritius semi-weight technique. Is it clear, guys? Okay, and about ECV, guys, remember that I'll mention that again, guys. If you have a shoulder presentation with a transverse lie, you will go with the cesarean section. If breech and shoulder has a transverse lie, you will go external cephalic version. But at how many weeks? 37 weeks. External cephalic version you will not do at 30 to 32 weeks, because the amniotic fluid keeps increasing and baby will change its prior position if ECV is done. So remember, guys, if transverse lie, patient is in the labor, cesarean section. If not in labor, you will go with the external cephalic version. So the classical answer here, you have a breech presentation, guys. What is your next step, guys? You will do ECV at 36 weeks. You will do ECV at 36 weeks. Is it clear to everyone out there? Please write down in the comment section, guys. Just let me know. Is it clear now? Is it clear now? Anji. Chalo, guys, next question. A primary gravida, 37 weeks of gestation, reported to the labor room having marginal posterior placenta previa with a painless bleeding. per vaginum. The fetal heart rate was normal at the time of examination. The best management option for her, guys, placenta previa at term. What is your answer? Faster. Placenta previa at term. What will be your answer? Placenta previa at term. What will be your answer? We have discussed just now. Just now we have discussed placenta previa at term. What will be your answer? Placenta previa at term. Your answer is going to be? Your answer is going to be? Yes. Expectant management, cesarean section, induction and vaginal delivery, induction and forceps delivery. Very good. Yes, right. Your answer is going to be cesarean section. Your answer is going to be cesarean section. Your answer is going to be a cesarean section. We have already discussed, guys. If a placenta previa at 37 weeks will come, you go with the LSCS. If placenta previa before 37 weeks will come, guys, your answer is going to be expectant management. That is a McFay-Johnson regime. What is McFay-Johnson regime, guys? Resuscitation of the patient, bed rest. If RH negative, give anti-D and give the steroids for the fetal lung maturity. What are the steroids? We'll give beta-methasone and dexamethasone. Beta-methasone, how many doses? 2 doses, 12 mg. Okay, and dexamethasone, guys, 6 mg, 4 doses. Is it clear, guys? And if at 37 weeks you are coming, you go with the cesarean section. Is it clear? Already discussed. So what is the presentation of the patient having a placenta previa? She's having a painless bleeding. Kya hoga usko? Painless bleeding. Next question. Okay, guys, painless bleeding. Painless bleeding. And your diagnosis is placenta previa. Your diagnosis is placenta previa. Chalo, guys, further. Next question. A drug of choice in postpartum hemorrhage resistant in all routine drugs. Okay, guys, now let's discuss a drugs of PPH. Okay, drugs of postpartum hemorrhage. Okay, now if I talk about the prophylactic drug, if I talk about a prophylactic drug, so prophylactic drug that we use in PPH, we have oxytocin, 5 to 10 units. Okay, then the drug of choice is also oxytocin, but you will give 10 to 20 units. Drug of choice. Okay, no bolus. It was a question asked in the NEET PG, guys. No bolus. Why? It can cause sudden hypotension. It can cause sudden hypotension. It can cause sudden hypotension. Okay, and now that's why, guys, never give bolus oxytocin. Okay, give in a drip form. Give in a drip form. After that, the second drug of choice, your second drug of choice, your answer is going to be second drug of choice, methyl ergometrin. Your second drug of choice is methyl ergometrin. Okay, and this methyl ergometrin, guys, it has a peak action in 90 seconds. Peak action in 90 seconds. But there is a contraindication of this methyl ergometrin. Remember, it is contraindicated in pregnancy induced hypertension. It is contraindicated in heart diseases like patient is having a mitral stenosis during the pregnancy, so this drug is contraindicated. Patient is RH negative and delivery of the second twin, before the delivery of the second twin, this methyl ergometrin is contraindicated. This is all the important questions. Then further, guys, we can use misoprostol as well. Okay, then the best drug, which is injectable drug that we use, is carboprost. Now, my dear students, this carboprost, you can use a single dose of 0.25 mg and a maximum of 8 doses. Maximum of 8 doses. So that means a total 2 mg carboprost can be given. This was a NEET PG question, guys. The carboprost is an injectable drug, so it's only injectable drug. And remember, guys, this carboprost is a prostaglandin F2 alpha. Prostaglandin F2 alpha, This carboprost is a most potent drug, or it's a most potent drug, and when there is a resistance of all the drugs above, your drug of choice, routine resistant, your drug of choice is going to be carboprost, guys. So methyl, if oxytocin and methergine is not working, so that means the postpartum hemorrhage resistance is all routine drugs, then you go to the injectable drug carboprost. Dinoproston, my dear students, it is a gel form used vaginally for an induction of the labor. Methyl ergometrin I've discussed already. Misoprostol is a prostaglandin E1 which is used. Are you getting my point? Then if the bleeding is still not stopping, we go with the क्या करते हैं फिर guys? We go with the balloon tamponades, we go with the Buckley balloons, we go with the Foley's catheter, we go with the Sangastican tube, okay? Followed by that, if the bleeding is still not stopping, we go ligate the arteries. What is the order of the arteries that are ligated? Uterine artery, ovarian artery, and internal iliac artery, okay? And internal iliac artery, uterine artery, ovarian artery, and internal iliac artery. Which branch of internal iliac artery, my dear students? Sir, anterior branch, okay? Why not posterior? Because that goes to the lower limbs and patient will have a numbness or the paralysis of the lower limbs followed by the ligation of a posterior internal iliac artery. What are the branches of posterior iliac artery? I will write here branch of posterior internal iliac artery. What are the branches, my dear students? Your branch number 1 is going to be superior gluteal. Number 2, iliolumbar, and number 3 is lateral sacral. It's lateral sacral. It's superior gluteal, iliolumbar, and lateral sacral, okay? Remember that. And if a bleeding is still not stopped, then your last option is going to be hysterectomy. Your last option is hysterectomy. Your last option is hysterectomy. Is it clear to everyone, guys? So the most potent drug is carboprost, which is an injectable drug, okay? The only injectable drug we are giving, guys, it is carboprost, okay? It is carboprost. Next question. Let's move to the next question, guys. A woman had 3 consecutive abortions in the 2nd trimester, okay? A woman had 3 consecutive abortions in the 2nd trimester. Anatomical causes. What should be the best method to manage her condition? What should be the best method to manage her condition? Okay. Chromosomal analysis, guys. Chromosomal analysis. Usually chromosomes abnormalities are the cause of a 1st trimester abortion. Performing a prophylactic cerclage, examples are McDonald cerclage. My dear students, I'm not giving you a history that the patient is having a cervix less than 2.5 centimeters, so no need of a cerclage or a McDonald's cerclage, okay? Now this 2nd trimester abortion, it is an anatomical cause, I know, yes. So what I will check the anatomy of the tubes, I will check the anatomy of the uterus, okay? I will check the patency. Are you getting my point? I will check the anatomy. For that your best investigation here will be hysteroscopy and laparoscopy. So hysterolaparoscopy, okay? Hysterolaparoscopy. It will tell me about patency of tubes. It will tell me about a patency of tubes. It will tell me about anatomy of tubes. And laparoscopy will also tell me about adhesions. Laparoscopy will tell me about adhesions as well, because laparoscopy is a investigation of choice for endometriosis as well. This was the question asked, guys. A patient coming to you, a middle-aged woman with complaining of dysmenorrhea, dyspareunia, okay? Dysmenorrhea, dyspareunia, menorrhagia, okay? On pathological investigations, guys. On laparoscopy findings, there is a chocolate cyst and a powdered burn lesions. What is your diagnosis, guys? It is endometriosis. So chocolate cyst, powdered burn lesions, adhesions is a classical case of an endometriosis. Okay, third to fourth decade, what will be your treatment? Medical treatment. As patient is still 25 to 35-year-old, you will give a drug which will do atrophy of the endometrium. So what are the drugs that are doing the atrophy of the endometrium? Danazol, which is an anti-estrogen. Why? Because estrogen is responsible for the proliferation of endometrium. Okay, now in endometriosis there is a hyperestrogenic state. So what we have to give? We have to give anti-estrogen, danazol. Okay, we also use injection depot medroxyprogesterone acetate, 150 mg in 3 months, which will also cause an atrophy of the endometrium. But among these two drugs, my dear students, which will cause the faster atrophy, that is the anti-estrogen, danazol. But danazol has a side effect called as virilization. What do I mean by virilization? Breast atrophy, clitomegaly, and hoarseness of voice. Okay, and what is the first symptom that will stop this drug? Hoarseness of voice. Is it clear to everyone, guys? Further drugs, we can use GnRH analogs as well. So they will cause down regulation of the pituitary. जब pituitary से हार्मोन ही कम आएंगे तो proliferation ही कम होगा. Okay, so that goes with the treatment of endometriosis. And investigation of choice for endometriosis, guys, it is laparoscopy. So best choice here to check the condition, guys, as she's having 3 consecutive abortions. So to check the adhesions, to check the patency of the tubes, anatomy of the tubes, your best choice among A and B is hysteroscopy and laparoscopy. It's hysteroscopy and laparoscopy. Okay, so is this done, guys? Everyone? Yes, it is done. Okay, one more question, guys. A chorionic villus biopsy is done for all of the following except. Now chorionic villus biopsy in all of the following except. Okay, neural tube defect, sickle cell anemia, myotonic dystrophy, and Down syndrome. Guys, sickle cell anemia, yes, we can go for chorionic villus biopsy, 10 to 13 weeks. Myotonic dystrophy, yes, you can go with a trinucleotide repeat, है CTG, having a Christmas tree cataract. Down syndrome, trisomy 21, yes, you can go and for chorionic villus. For neural tube defects, I'm already telling you guys, we are going for what? Amniocentesis. क्या करते हैं हम? Amniocentesis. Okay, we usually do by 16 to 18 weeks. Amniocentesis. And to check the neural tube defect, we are checking acetylcholinesterase. We are checking the acetylcholinesterase in amniotic fluid. That will tell me about a neural tube defect. Okay, neural tube defect, guys, you to prevent you give vitamin B9. You give vitamin B9, folic acid. Okay, remember this, guys, you give vitamin B9, folic acid. Okay, how much? 0.4 mg. 0.4 mg. If history of neural tube defect, then how much? 4 mg. Then 4 mg or 4000 micrograms. 4000 micrograms. Okay, most common neural tube defect that is seen is spina bifida. Most common spina bifida, you have spina bifida occulta. Is it clear, my dear students? You have which sign? Lemon sign and banana sign. So you see in the head, lemon sign, banana sign. Okay, and as per the anemia Mukt Bharat, how much folic acid, guys? 60 mg iron and 500 micrograms of folic acid. Anemia Mukt Bharat बोलता है 60 mg pregnancy and 500 microgram folic acid in case of pregnancy and lactation. Is it clear, guys? So that was all about this. So neural tube defects, we go for the amniocentesis. Okay, चलो गाइस, मायोटोनिक डिस्ट्रोफी में इट्स अ ट्राइन्यूक्लियोटाइड रिपीट डिसऑर्डर गाइस. इसमें क्या होता है? CTG, ट्राइन्यूक्लियोटाइड रिपीट. वी हैव अ क्लासिकल टाइप ऑफ कैटरैक्ट एज वेल, क्रिसमस ट्री कैटरैक्ट. डाउन सिंड्रोम में यू ऑलरेडी नो व्हाट इज द मोस्ट कॉमन कार्डियक डिफेक्ट इन डाउन सिंड्रोम, गाइस. It is endocardial cushion defect. Is it clear? So this was all about today, guys. Okay, next time hopefully more topics. Okay, so remember, guys, you got this. You got this, guys. And keep revising the questions, keep revising all the stuff. Watch these all three videos. If possible, I'll come up with a part 4 as well. Okay, so I hope every one of you understood. The discussion was highly enough, and you guys are able to answer now. Is it clear? So if anything to ask, guys, you guys can ask me doubts related to the pathology, related to the any subject, guys. If I know, I'll reply to you guys, I'll answer to you guys. So make sure, guys, you remember, make sure you remember, you revise, and you keep solving the questions. Give GTs, guys, and revise those GTs, analyze yourself, because and try to increase your speed in the mock test, because now there's a time bound sections. So yes, anyone, any doubts? All good? Okay, very good, guys. Okay, so revise. Okay, you guys are welcome. I hope, guys, explanations and detailed whatever was delivered will be good, useful enough for you guys in exams on July 6th. Keep revising. Also, Meduhub is coming with a Sankalp rapid revision. Will you gonna take other subject sessions too? Not sure, guys, not sure. I'll have a offline rapid revision session in Delhi maybe. So let's see about rapid revision later on. But yes, you guys keep revising and keep solving the questions. Revise these all the three high discussions of PSM and OB-GYN. Okay, general path is a bit in a detail. So but for this OB-GYN and PSM, guys, they are the scoring subjects. Revise this stuff and keep solving the questions. And if you have any doubts, guys, ping me up. So don't compare your knowledge with anyone. Keep going. Good luck, everyone. Thank you, guys. See you very soon. Allah Hafiz.